So this one is specifically for the medical students. One of the most common questions that I get asked is, how do I know which medication to choose for each individual? And my answer is that I tailor it to the person. Think about if you were treating hypertension, for example. How do you know which antihypertensive to choose if somebody is hypertensive? So for example, if somebody is hypertensive but also is diabetic, you may think lisinopril to protect the kidneys. If they're hypertensive but also tachycardic, you may choose a beta blocker like metoprolol to help with both of those things. If they're hypertensive and they have, let's say, diastolic hypertension, you may choose a diuretic like hydrochlorothiazide to decrease preload or similar. So let's say they have none of those things. Well, I guess you could choose amlodipine or similar. So it's kind of the same thing. I'm going to use SSRI as an example here. If you're treating depression and anxiety, I'm going to give you a little bit of my algorithm and how I go through this, and then specifically if somebody fails a medication, what to do next in terms of potentially choosing an adjunct. So here we go. These are the SSRIs. I mean, right off the bat, if somebody comes in and they're an adolescent, in my head, I'm thinking Prozac, because this is the one that has the most data in children and adolescents. So I would have to have a reason to not choose that. It just so happens as long as half-life, easiest to come off of. If somebody is telling me that they want something that's easy to come off of and that's a priority, I would also choose Prozac. Okay, you should know that Paxil is probably the one that is the most sedating, may be better in anxiety, but does have the most weight gain, the most sexual dysfunction. So these are things that have to be considered. Also, if you have OCD, for example, then the one that has been studied in OCD the most is actually Luvox or fluvoxamine. Doesn't mean the other ones are not as good, but it does mean that if you're going based on evidence-based data, you're going to choose Luvox generally. Zoloft, let's not forget, had the SAD heart study, the sertraline antidepressant heart attack randomized trial, which was a double-blinded placebo randomized trial, which showed that there was no statistically significant cardiac issues in people taking Zoloft. So if somebody is post-ACS, acute coronary syndrome or similar, then certainly you're going to think of Zoloft, I would imagine. Me personally, if let's say I get a consult on the nephrology floor and somebody's end-stage renal disease, well, I know that the kidneys and the heart are very related, so I may choose Zoloft because it tends to be a little bit more medically friendly. Lexapro will probably interact with less things in comparison to some other ones, and Celexa is also a good choice that's easy to get covered by insurance, etc. Now, let's say you've tried one of these medications and it fails. Let's say you choose Prozac arbitrarily for a second and it fails. I will generally come off of Prozac and try a second SSRI. So let's say I did that, right? Let's say Prozac failed, come off of it, try, let's say Lexapro. Let's say Lexapro fails. This is a hard situation to be in, unfortunately, because now you don't have as many choices and it gets a little bit harder to fix. You have a few choices. I will basically present to the patient all of their options. Option number one, they can come off of the Lexapro and try a third SSRI. Or at this point, they can consider what we call adjunct. Adjunct just means boosting it with a medication. Options for as an adjunct, there's so many options. And again, this means you maybe have a partial response to the SSRI. You don't want to lose that partial response. You don't want to come off of it completely, or the idea of coming off of it is demoralizing for some reason. Then you'll be in the market for an adjunct, technically. And popular adjuncts. I mean, let's go there. Wellbutrin, Abilify. Okay, we can keep going here. So some of the newer ones, Rexulti, I've used, personally. These are, again, my opinions here. Vraylar. Okay, these are just things that I have historically used as an adjunct. So there's actually a lot more options. Technically, any of the atypical antipsychotics, regardless of indications, it's just my opinion. I think almost all the atypicals can be added to an antipsychotic and boosted it. If you want to stay away from that, I mean, I've adjunct with things like lithium and Lamictal, for example. Lamictal, I think, is a great one. So bottom line is, how do I choose the medication? It's not really me, it's tailored to the individual. Hit me up in the comments.